We will now move on to part 2 of the cardiovascular disease lecture. So we'll be having a look at the management firstly of CHD and CAD. Firstly, looking into primary and secondary prevention in CAD. So primary is looking to modify risk factors or prevent their development with the aim of delaying or preventing the onset of coronary heart disease. Now, secondary prevention, we're looking at controlling the risk factors and therapeutic protection of the coronary arteries from plaque eruption. So essentially looking at the treatment of CAD. Before we look into exercise therapies for the management of these conditions, let's firstly have a look at other options available. So diet most definitely is a way of managing CHD, and the optimal diet that is in the prevention of this condition is non-hydrogenated unsaturated fats, good amounts of whole grains, lots of fruits and vegetables, an adequate amount of omega-3 fatty acids, and main diets that you would be looking at that follow these are your Mediterranean and DASH diets. So there is a lot of research behind these two particular diets and the great effect that they have on cardiovascular disease risk factors and the prevention of cardiovascular disease itself. So as a point, so it offers significant protection against CHD. And generally, you would expect in the management plan for this individual that there would be some form of referral to a dietitian to advise them on how they can best sort out a diet. Now we'll have a look at common lipid-lowering medications that are prescribed to those individuals with CAD or CHD. And the first line of treatment that is generally prescribed are a group of medicines called statins. And that's because statins have been so well researched in regards to significantly reducing the risk of CHD, strokes, and cardiac-related death. And the mechanism behind these medications are that they are a reversible competitive inhibitor of HMG-CoA reductase. And what you need to know is that this particular enzyme is the rate-limiting enzyme necessary for cholesterol biosynthesis. So essentially, in a nutshell, we're saying that they inhibit the production of cholesterol in the liver, which is a good thing. So we have two forms of how we actually produce or get cholesterol in our body. We have endogenous cholesterol, which is produced by your liver. And we also have exogenous cholesterol, which is how we get it through dietary means, so we eat it. If we can actually stop the mechanism of producing our own cholesterol, we can hopefully level out diminish any extra cholesterol that we've been producing and just have the. If for a reason a person hasn't reacted well to the first line of treatment, there has to be some other form of medication that we can prescribe to an individual, adverse reactions or side effects that occur. So stimbis are an alternative to the statins. So how they work in regards to managing lipids is that they inhibit intestinal absorption of the cholesterol and phytosterols. So phytosterols are really just plant cholesterols. And how they do this, so the difference between your statins and the stimbis is that these focus really on the exogenous cholesterol. So they control that because obviously food is going in through. Another common alternative to statins are fibrates. Now, fibrates interact with PPARs, which may reduce triglycerides by increasing fatty acid oxidation, by increasing lipoprotein lipase activity, and also by reducing ApoC3 synthesis. Now, apolipoproteins, which is what the apo means at the start of the ApoC3 synthesis. So these are proteins which are found on lipoproteins, which are your LDLs, HDLs, and VLDLs. And unfortunately, when a person gets to the stage of, say, needing lipid-lowering medications, there is already an abnormality in the metabolism of how these are processed, so your apolipoproteins, and also your lipoproteins. So in the literature, it's actually been found that if there is an impairment of the metabolism of apolipoproteins, it actually increases the risk of atherosclerosis, which is why fibrates, if they can reduce the synthesis of at least one form of these apolipoproteins, it can. So let's have a look at how these three medications actually manage lipid levels. Starting off with statins at the top. So as you can see with total cholesterol levels, it actually has a decrease of about 19 to 37%. For your LDLs, a decrease of 25 to 50%. It can increase your HDLs for about 4 to 12%, and your triglycerides can decrease by 14 to 29%. And the brilliant thing behind statins, so besides the good things that it does in regards to reducing the risk of cardiovascular disease, stroke, and all forms of cardiovascular types of mortality, is that it is very, very well tolerated by patients. So generally, most patients take on this medication quite well. So if we have a look at STIMBs, which is just underneath that, so the numbers aren't nearly as high in either reducing or increasing your cholesterol levels that we have here, but it is still well tolerated by patients. However, if we look at our fibrates down at the bottom, we can see it's quite consistent with the numbers of statins. So we can see here that, for example, the HDL levels are a bit more consistent with increasing that compared to your statins, which has a greater range. And it also can reduce your triglycerides at a bit of a higher rate. However, because the research doesn't support fibrates as much as, say, statins when it comes to reducing cardiovascular disease, it's why statins are still the favored medication for the management of lipids in this population. We will now have a look at some detail behind a myocardial infarction. So firstly, to reinforce, it is the medical term for a heart attack. The only time that you might see a little bit of a change to this terminology is when we're talking about the early stages of a heart attack, where it's just changed to an acute myocardial infarction. And the only change to that acronym is that it'll have an A in front of it. An infarction means to plug up or cram. And thinking about the basics behind the pathophysiology of a heart attack or an MI, hopefully you are aware that it is an obstruction to blood flow, which is why we have this pain as one of the main symptoms for a heart attack. And this blockage usually comes from a rupture of a plaque, which then eventually clots and forms a thrombus. And when this thrombus then dislodges, it then blocks the blood supply to the heart. As a result of this, it leaves the heart in a hypoxic state, so deprived of oxygen, which results in cell death, known as necrosis. The unfortunate result of necrosis is that for the heart itself, and there hasn't been an intervention yet that has been proven to change this, but unfortunately, once we have muscle cell death in the heart, we can't change that. Therefore, I want you to have a think about how having a reduced contractile component within the heart will affect its ability to do work. If this myocardial infarction has blocked off, say, the myocardium in particular, or a section of the myocardium, then this will reduce in what component being significantly reduced. Hopefully you've thought cardiac output, which is correct. And this is very, very important in terms of. Now we'll have a look at a summarized version of this in a picture. So we should see that there is a magnified artery at the top, which shows the blood clot, which is obstructing blood flow from that point onwards, and has led to this darkening in the tissue, which is quite a significant sort of presentation in terms of necrosis or cell death to that site due to the hypoxic nature that has now occurred around that tissue. Unfortunately, as I said previously, we cannot change the state of those cells that have died. However, we can have certain surgical procedures which can ensure that other parts around the site do not stay in a hypoxic state. And what we'll do later on is have a little chat about those surgical interventions. All right, so if you're working with high-risk cardiovascular patients, it is extremely important that you are aware of the signs and symptoms of a myocardial infarction. So think back to your first aid. The first thing that you should notice, or one of the main signs and symptoms that do occur as a result of a heart attack, is pain, and lots of it. So generally the person firstly feels chest pain, and then it's usually referred down the left side through to the arm. Why do you think pain would be present? Hopefully you've thought about the ischemia that is happening at the site. So once we become oxygen deprived, it becomes quite painful, and we're having muscle cell death occurring, which again is a very painful process. However, it is completely possible for a person to have something called a silent MI, where they have no apparent symptoms that are present. The only time that you will probably see this is during an exercise stress test when you have an ECG hooked up to an individual, and the ECG in certain leads shows a significant change that is indicative of an MI. Other common signs and symptoms are shortness of breath, syncope, sweating, nausea, vomiting, weakness, and eventually, if they don't get medical attention soon enough, cardiac arrest. However, there are times when we do see a myocardial infarction in an individual where the signs and symptoms themselves don't present in their common pain pattern. So as you can see here, generally when it comes to chest pain, it usually is towards the center or the left side of the chest. However, in some individuals, there is still referring of pain down both arms. Some people complain of a feeling of indigestion or even heartburn when it comes to having a myocardial infarction. And sometimes people don't even experience chest pain itself. So they're either feeling it in their back or just in their arms. So remember, if somebody is presenting with the other signs and symptoms, just make sure that you are taking extreme caution with this individual, and particularly if they are a high-risk cardiac patient, make sure that you check through your first aid first and have medical attention there straight away. While you do have your ECG lecture the following week, here is just the criteria of the diagnosis behind a myocardial infarction, or the abnormalities that you will see in a cardiac rhythm when it comes to a 12-lead ECG. What I'll get you to do is review this after you've seen your ECG lecture and see if you can identify the certain things that are listed here. So in post-MI, the most significant change that we generally see is some form of ST segment depression and T-wave inversion. So you will learn with ST segment depression, it is indicative of ischemia to the site of the heart. And this will be present in particular leads where this muscle cell death has occurred. If you are identifying an MI during its actual attack, and for example, this will be happening during an exercise stress test, you will see ST segment elevation. And once you see that, you stop the test, you get them ready to have some form of defibrillation, ready to go and get ready for CPR. So you can see that we can identify on particular parts of the heart where this myocardial infarction is occurring. And what we have here are the different walls that are related to the different 12 leads there. And as you can see, certain sections correlate to certain areas of damage. Again, what I'll get you to do is review this once you've seen your ECG lecture and see if you can identify the abnormalities on that rhythm strip that is provided there for you. Besides an ECG, how can we figure out if an individual has had a myocardial infarction? Other diagnostic tools that are available are blood tests. So we have a creatine kinase blood test, which can determine whether the increase in creatine kinase in the body is due to either heart damage or skeletal muscle damage. The physiology behind creatine kinase is that creatine kinase elevates as soon as there is any muscle cell death. The thing about this test is that it is more specific to skeletal muscle damage. And if this test comes out elevated, then we know we need to do or implement another test that is more specific to the cardiac muscle, which is why generally now the troponin test, the blood test, takes precedence. It is cardiac muscle specific, and looking at these levels of troponin, the only time that there is an increase or significant increase in these numbers is when we do have myocardial necrosis occurring. This can be detectable from 3 to 6 hours after an acute MI, and concentrations can still remain elevated for 14 days. So at least if for some reason a blood test isn't taken nearly close to post the event, we can still see some form of evidence in their blood for quite some time after that. Another way that we can have a look at an MI is if somebody has something called an echocardiography, which is where we have the ultrasound being placed around the chambers of the heart and having a look at that picture and seeing where the damage has happened to what particular site of the heart. And then we can also have a process of cardiac catheterization. And hopefully if the person gets into the hospital quick enough, we can get rid of the problem and solve it by dissolving the clot or removing the clot from the site and have a stent being put in place instead of having a more invasive surgical procedure. As a result of an MI, the first thing that you should be thinking is that this individual has now most definitely developed ischemic heart disease. And we need to provide treatment options to allow them to have sufficient myocardial blood flow, as well as reducing the demand on the heart so it's not overworked in order to maintain the cardiac output that the person needs. So common medications in regards to the treatment of ischemia is looking at firstly the ones that do increase myocardial blood flow to the site. Nitrates is a very common type of medication and should be. So once you've heard that an individual has a history of an MI or other surgical interventions that are associated with an MI, they most definitely must have all of their nitrates with them at every single session that you see them. So commonly there is a nitrolingual spray which they spray on their tongue, or they have tablets. So the benefit of having these medications is that they act as a powerful vasodilator around the site of the chest and around the heart. So an angioplasty can be done, which is what we were talking about with the cardiac catheterization. So once that happens, the angio or the catheterization, is performed usually with an incision to access the femoral artery, and the catheter is then traveled through this artery towards the heart to find the damage. And through this angio procedure, we can balloon out the blockage and then return the luminal diameter, or circumference, back to close to where it was before to allow for sufficient blood flow to go through. Generally now during this process, a stent will be put in place to ensure that this part of the vessel or the artery will stay open. And we can have something that's a lot more invasive called a bypass surgery, commonly known as CABG, so CABG. The actual name of the surgery provides quite an easy description of what's happening. So unfortunately for these individuals, the surgical intervention will require them to have something called a sternotomy, where the surgeon will actually go through the sternum, open through there to access the heart, and exactly what it says there. So by taking out veins from the leg and bypassing the damaged area to ensure that blood flow still goes to other areas around the damaged site. Now looking at medication involved with reducing myocardial oxygen demand. So you have beta blockers. So for example, if we have an increased heart rate, it means our heart is working harder. Therefore, we have an increased myocardial oxygen demand. Beta blockers actually reduce the heart rate and blunt the heart rate response. So when we're looking at exercise testing, for example, in these individuals, it must be noted that these people will have a blunted heart rate response. Nitrates can do this by that vasodilatory action, and we have afterload reducers that reduce the amount of pressure that is being placed on the myocardium itself. And preventing any form of coronary artery spasms. So calcium channel blockers essentially do exactly that. So remember that we have calcium that activates the actual cardiac contraction to push the blood to the rest of the body. And fortunately, these have been designed to be cardiac muscle specific. So instead of having a systemic effect where we affect skeletal muscle contractions, we're just only looking at reducing the cardiac contraction rate or abnormality in the electrical conduction of the heart, as opposed to affecting the muscle as well. Other common medication treatment options for the management of IHD, lipid lowering meds. So we've already talked about the function behind those and why they would be important in regards to the atherosclerotic process. But a lot of individuals will also be on antihypertensive medications. So the first ones that are generally, as the first line of treatment, are ACE inhibitors. And how they work is that they block the angiotensin converting enzyme for conversion of angiotensin 1 to 2. And behind the physiology with all of that, so we have a certain system that is involved with angiotensin. So angiotensin 2 is a powerful vasoconstrictor. So hopefully what you take as a message in regards to hypertension, remember that peripheral resistance plays a huge role in terms of what our blood pressure will be like. So essentially, if we can reduce the constriction that is happening around the vessels, we can also reduce the amount of pressure that is going around our vessels in our body, as well as around our heart. However, if for some reason that isn't enough as a treatment, we have an individual also on angiotensin receptor antagonists. And what they do is block angiotensin 1 receptors to stop their action of converting into angiotensin 2. Other common sort of stuff as well are anticoagulant and thrombotic medication, which should make a lot of sense. We're trying to change that consistency of the blood, ensuring that it isn't an environment where we can make it easier for the individual to clot. So common medications that are prescribed are heparin, warfarin, and aspirin. So these act as trying to thin the blood out to ensure that, again, there is a reduced work on the heart, but creating an environment that we don't want to have these cells coagulating together and creating a clot. And nitrates, and we've already talked about their role in ischemic heart disease. So eventually get the chance to have a look at the YouTube video looking at angiogram and stents. And if it doesn't work, just let me know and I'll try and figure out a way for you to get access to that. If you do have any questions on this section of the lecture, please send me an email. And again, have another brain break before we move on to section